Hello everyone, I am Dr. Deepak Talwar. I am Secretary Indian Chest Society and I am a pulmonologist working at Noida Metro Center for Respiratory Diseases. There is an association between API and ICS to provide respiratory updates to physicians, and it has formed a body called EPICS. EPICS webinars are coming your way, and considering the high interest and emphasis on the lung health in the current times, this is going to be a monthly series. Twice a month, it will be coming on 2 Saturdays, and it aims at providing a complete update on advances and diagnosis of management of some of the respiratory diseases which are of importance to our physicians as well as respiratory physicians. This will be based on case-based discussions and what we routinely encounter in our daily practice. So this webinar is going to be a great way to help us enhance our knowledge to treat our patients. And of course, this seminar is aimed at not only physicians but also respiratory physicians, and hence we'll have mix of physicians as well as respiratory physicians discussing it on the table and giving the messages which can be implemented in our daily practice. So do join in for this EPICS webinar, which is going to be on 11th March, 8 p.m. onwards. And the knowledge partner for this is Glenmark.
Hello everyone, it's my immense pleasure to welcome you all on this API ICS Respiratory Update online series. API and Indian Chest Society have joined hands to pursue the common goal to update the knowledge of respiratory physicians and practicing physicians in the field of respiratory medicine. There has been a spurt recently in respiratory cases and post-COVID complications, and a need was felt to update the knowledge of practicing physicians at a grassroots level. And I hope this online series of respiratory update will go a long way in achieving this goal. We will organize these programs at a regular basis as a case-based discussion, and will invite distinguished faculties to share their knowledge and skill. I compliment and congratulate Dr. Deepak Talwar, Secretary Indian Chest Society, Dr. Jyotirmay Paul, Dean Indian College of Physicians, and Dr. Agam Vora, Secretary API, for taking this wonderful initiative. I welcome you all again this evening and extend my best wishes for this program.
Welcome all the delegates. I am Professor Dr. Jyotirmay Pal, Dean Indian College of Physicians, that is the academic wing of Association of Physicians of India. I welcome all the physicians and students to this joint symposium of Association of Physicians of India and Indian Chest Society. It is my intention to enable different associations to come together and organize such collaborative endeavors for the advancement of knowledge and mutual exchange of wisdom that will ultimately lead to upliftment of standard of medical care. Hope this joint symposium of Association of Physicians of India and Indian Chest Society will update our members on the recent advances on respiratory medicine. Jai Hind, Bande Mataram, long live API, long live Association of Chest Society. Thank you.
You can start, ma'am.
Good evening, everyone. It is my pleasure to welcome you all to this part 2 series of COPD management of the APEX. Dr. Agam Vora is unfortunately caught up elsewhere, so he is not here, so I will be handling this session. For those of you who don't know me, I am Dr. Pratibha Singhal. I'm a pulmonologist in Mumbai. And we have with us here 2 budding chest physicians. First, Dr. Harshita Mishra, who is a senior resident at the Department of Respiratory Diseases, LTMG Hospital, Mumbai. And we have with us Dr. Shayan Chakrabarti, who is a fellow at the Metro Center for Respiratory Diseases, Noida, and is working with Dr. Deepak Talwar. And we have with us for this part of our discussion of the management of COPD, Dr. Chandrakant Tarke, who is a pulmonologist attached to Apollo Hospital at Jubilee Hills, Hyderabad. He is very avid academician, and I hope we get to learn a lot from him. And we have with us another young physician, Dr. Hani Savla, who has filled in at the last moment, and I'm thankful to her for this. She is a full-time consultant in internal medicine at the Wokhad Hospital, Mumbai Central in Mumbai. So I welcome you all, and we will proceed with our first case. Harshita, if you can please take over and show your slides. You're on mute, Harshita.
Good evening to all the respected faculty and a warm welcome to all the audience. I'd like to proceed with my case. So we have, this is the relevant background information. We have Mr. X. He's a 40-year-old gentleman. He has a body mass index of 21 kilogram per meter square. He presented with chief complaints of cough with about 5 to 10 ml of mucoid expectoration for the past 1.5 years. And he had breathlessness while he was climbing 2 flights of stairs for the past 6 months. Patient, on inquiring about the relevant triggers and exposure, he is not giving any history which is suggestive of atopy. He is not giving any history suggestive of any allergy exposure. He has a smoking history, which is counting to a 10-pack-year history of cigarette smoking. He gives no history, which is suggestive of rhinitis, gastroesophageal reflux disorder, and obstructive sleep apnea. And he's not giving any history suggestive of anxiety or depression. On asking further history, is not giving any past history, no significant family history. Patient is a software engineer by occupation. He has no history of loss of appetite, loss of weight, no history of any viral infections in childhood, no history of tuberculosis. But he has a history of prematurity. He was born on 7 months of gestation, and he had required a neonatal intensive care for 8 weeks. He does not give any history suggestive of any upper respiratory tract problems. So no history suggestive of sinusitis, no history suggestive of watery eyes, rhinitis, sore throat. And he is not on any current medication otherwise. When we examine the patient, he is not having any respiratory distress. His saturation levels are maintained on room air. He does have bilateral diminished breath sounds. CAT score is 9, and all the other systems are within normal limits. So we did the initial laboratory investigations of the patient. Hemoglobin was 14 gram percentage. WBCs was 7,600 cells per microliter, and a differential count showing 70% neutrophilic predominance, 20% lymphocytes, 7% eosinophils, and 3% monocyte. Absolute eosinophil count was 532. The liver function test, renal function test, blood glucose were all normal, and the electrocardiography showed a normal sinus rhythm. This is the radiograph of the patient. As we can see, there is a generalized hyperlucency with diminished bronchovascular markings. Bilateral hemidiaphragmatic contours appear a little flattened. And if we were to count the anterior ribs, we would see that more than 6 anterior ribs are visible. So this is a generalist picture of a hyperinflated chest as seen on a chest X-ray. We did a spirometry of the patient. The FVC was 2.49 liters pre-bronchodilator, and post-bronchodilator was 2.89 liters with a 16.4% change. FEV1 was 1.64 liters pre-bronchodilator and 2.15 liters post-bronchodilator with a 31% change. FEV1 by FVC was 65.98 pre-bronchodilator, and post-bronchodilator it was 74.3. And the maximum mid-expiratory flow was between 25 and 75% was 0.83 liters pre-bronchodilator and 1.24 liters post-bronchodilator. So we can see that the post-bronchodilator FEV1 by FVC is, the ratio is normal. It is 74.3, which is more than 70, but there is a reduction in the FEV1, and the percentage change is 31%. So that shows that there is a bronchodilator reversibility present in this patient. So a gold AB assessment tool was applied, and the patient has had the patient has not had any exacerbations as such. Also, the MMRC score is less than 10. So the patient is falling into category A of COPD. So we did a diagnosis, and it was COPD group A. Because CAT score was less than 10 and there was no history of exacerbation. So the first question is that what would be your goals of treatment in a patient who has come with this presentation?
So since we've already discussed how to diagnose COPD last time, Harshita has just recapitulated the same two cases. We are going to discuss the same two cases and take it forward and how to treat these two cases. And we have already put this patient into a category A because there has been no history of exacerbations and the patient's CAT score is less than 10. And therefore, we have put the patient in category A. So, Dr. Honey, when such a patient comes to you, what would be your primary goals of treating this patient? You're on mute, Honey.
Yeah, now I'm audible, right?
Yes.
Yeah, so the main goal is that, he should be able to do his activities of daily living very nicely. So we need to improve his exercise tolerance. Overall health status has to be improved. We saw that the BMI was only 21 and we need to relieve the symptoms. So the main thing is to reduce the symptoms and reduce the risk of the disease progression further. So which can be done by, preventing exacerbations, various ways to prevent exacerbation of seeing the compliance vaccination and to reduce mortality in general for future. So the main thing is to reduce the symptoms for this patient and to reduce the risk of future hospitalization and future infections basically.
Okay, great. So I think in this patient, because his primary symptom is breathlessness, we are aiming to primarily relieve his symptoms at this point in time because he's not had much exacerbation and of course reduce this risk of disease progression. Great, Honey. Please go ahead, Harshita.
The next question would be that what medications would we initiate this patient on?
Okay. So, Honey, as a physician, a lot of times these patients first come to you. So
Right.
what would be your primary? How would you start treating this patient pharmacologically?
Yeah, so basically the thing is that first we have to start this patient on long-acting agents because patient is having breathlessness right now. So we will go for a bronchodilator and we'll go for, if required, we have to add a LABA plus LAMA for this patient. Now, because this is CAT more than 10, right, Harshita? The CAT was more than 10 for this patient, right?
Not on 9.
The CAT score was 9. It was less than 10. So
Less than 10. Okay. So we'll go for bronchodilator for this patient initially.
Okay, good. So I think Gold, has very nicely categorized these slots and helped us identify what category to put these patients on. And going forward, I'm sure Harshita will post more questions which will explain to us why, which category, and what is the evidence we can discuss further. Yes, please go ahead.
So this patient was started on a DPI formoterol, which is a dry powder inhaler, formoterol 200 micrograms, 2 puffs, which were twice a day, and the patient was followed up. Initially, he did well, but then he started having symptoms of progressive cough and breathlessness again after 6 months.
So he was initially put on LABA, right? A long-acting beta-2 agonist.
Yes, ma'am. He was put on formoterol, but he again started worsening after 6 months. So in such a situation, what would we do next?
So Chandrakant, maybe by now the patient is now wondering what is happening to him. I'm taking my inhaler. What do you think? Will you first assess?
Initially, ma'am, in every visit, we should assess the inhaler technique because majority of the patient, even after giving the inhaler, they will not take properly. And other things also, patient should stop the smoking. If the patient is smoking, that is also important aspect. And even if the inhaler technique is correct and still the patient is having symptoms, as our patient was in category 1, that group A, in this only bronchodilator is a treatment. In these 2 drugs are there, either LABA or LAMA. Usually LAMA is preferred or LABA. Already patient was started on LABA, and as the still symptoms are progressing, I would prefer to add additional drug, that is LAMA. Means already patient is on formoterol. I will add mostly additionally either tiotropium or glycopyrronium. This should be my plan.
Go ahead, Harshita, because please go ahead with your next question. Yeah. So I think Chandrakant has already partly answered this. Maybe you can just continue this. What is the evidence on would you like to discuss some evidence on what is the evidence on whether LAMA is better versus LABA? Because Chandrakant, you did mention that data says that long-acting muscarinic agonist is better than a long-acting beta-2 agonist. So for the sake of the audience, if we can discuss, I think there are some trials. There is a huge Cochrane review which has analyzed 6 large and randomized trials which are showing that tiotropium like LAMA versus LABA, and they found that the LAMA was better in decreasing exacerbations compared to LABA alone. though at this point our patient has not had any exacerbations. So there could be any, I mean, if the patient presents to a primary care physician, he may not be completely wrong in adding, starting a LABA, but yes, if there was a history of exacerbation, maybe a LAMA would have been a better choice than a LABA. Yeah, go ahead.
What are the different options of LAMA and LABA which are currently available to us?
Yeah, Chandrakant, would you like to please elaborate on
Yes,
this?
in LABA, usually we have the salmeterol, formoterol. These are the almost 12 hours acting drugs. But if you want to go ahead or the longer acting, that is the 24-hour acting, the indacaterol, oledaterol, and vilanterol, these are the newer drugs. And compliance is better with the 24-hour acting drugs. And even symptom control is better. And that is the reason I think nowadays there is more trend to start the longest acting, like the indacaterol, vilanterol, especially from the compliance point of view. Second thing related to
Go back, please.
LAMAs. LAMA, we have the shorter acting, that is ipratropium, but LAMAs, longer acting, we have the glycopyrronium, tiotropium, clinidinium, and umeclidinium. Tiotropium is also longer acting, and even umeclidinium is the longest acting drug. And I think these are the options available with us.
I think we have most. I think in the LABAs, we don't have olodecterol available with us yet, right?
Yes. Only in India, we have the indacaterol and vilanterol.
Correct.
Yes.
But we do have a lot of choice in our country and a lot of combinations and this thing. So just to add on, because you did mention about, single dosing, single once a day dosing versus twice a day dosing. Any dosing preferences that you would have in any particular patient?
Ma'am, especially if the patient, those who are office working or they are not much compliant with the treatment, in such patient, I would prefer the longest acting, that is the indacaterol or vilanterol in such patients.
Correct. I think with some patients, if they complain of poor sleep quality or nocturnal symptoms, and in those patients, maybe twice daily dosing would be a better option. So some category of patients do have nocturnal symptoms, especially in COPD. Yeah. Go ahead, please, Harshita.
So on follow-up of our case, the inhaler techniques were checked. There was no history of any exacerbation after starting the treatment. Patient was started on formoterol plus glycopyrronium, as was previously mentioned, a LABA plus a LAMA. And over the next year, patient had 2 episodes of acute increased symptoms requiring acute management. And he was diagnosed to have an exacerbation. So how would we define exacerbation and how would we define its severity?
Yes, Dr. Hani Savla, if you would like to elaborate a little bit on this, please.
Yeah, so the problem with this patient is the exacerbation, because with every exacerbation, they may also require hospitalization. So exacerbation is basically a stable patient has an acute worsening of respiratory symptoms, because of which we have to add on our therapy. So in this also, we have categories like mild, moderate, severe. The reason why this exacerbation occurs commonly is because of infection or exposure to pollutants or any other reason because of which there is an insult served to the lungs. So these exacerbations can be mild, moderate, or severe. And treatment varies according to that.
Correct. Yeah. So why are we so worried about these exacerbations, Dr. Savla? I mean, because now we are now trying to phenotype all our patients. Now COPD patients, we try and phenotype into the ones who are more symptomatic versus the ones who have more exacerbations. Because exacerbations can happen irrespective of the lung function status. You can have patients who have reasonably good lung functions, but they keep having exacerbations. So why are we so worried about these exacerbations?
So with every exacerbation, there is a decline in lung function. That is the thing which we are afraid of. And that increases further the chances of mortality. Of course, disturbs the quality of life and of course the finances. With each expense of the hospital we know is increasing nowadays, the medications and everything, the more modern medicines we are having, the more costlier they get. So all of this adds up to a burden to the patient as well as increases his mortality. And that is why we are more worried about each exacerbation that occurs.
Correct. So Chandrakant, do you have patients in your hospital where you have to counsel them and explain to them the economics of an exacerbation admission versus taking a LABA-LAMA therapy? Because often they love taking their blue inhaler, which is a short-acting beta agonist, because it is still cheaper than taking these combinations. So, I mean, how do you convince them that this is what they need to do?
This is a very good point, ma'am. Usually, we need to explain them. These shorter acting medicines, SABAs and short acting ipratropium, these are acting very for shorter term, 4 to 6 hours only. And if you use slightly other longer acting medicines, slightly costly, but cost is definitely less than the cost which occurs because of the hospitalization.
Correct.
Hospitalization will lead to increase cost, increase suffering, increase morbidity, and absenteeism from the job. These are the various aspects. That's why I miss cost of using the longer acting medications is very, very less in front of the cost, which is because of admissions.
Correct. So sometimes what I tell my patients is I actually show them the cost of a 5-day admission, not in just the ward in a corporate hospital versus the entire year's combination therapy of LABA LAMA, and they'll realize actually it is more worthwhile, more economical to just take that inhaler rather than coming back again and again. Because all of us are working in, Harshita is working in the public sector. There are different issues, but in the private sector, even 3-day admission is much more expensive for them.
Correct.
Okay, please go ahead, Harshita.
So we have defined that the patient has an exacerbation. What would be the next assessment on follow-up of the patient? And would we add any other medications to the patient?
Yes, Chandrakant, if you could please elaborate.
If you see now, in aspect of dyspnea, in this patient, we started initially on the LABA, but patient was not improving. Then we added a LAMA. This is the second step, obviously. And in some cases, if you switch the inhaler, that also helps a lot. If the patient is not able to generate adequate volume with the dry powder inhaler, if you change to meter dose inhaler with the spacer, that also works well in some patient. And wherever possible, we should de-escalate or escalate the treatment whenever is required. And in exacerbation, especially if the patient is in a frequent exacerbation and patient is having increased eosinophils and there is a component of asthma, concomitant asthma, we should add the inhaled corticosteroid, that is LABA, LAMA plus ICS. Usually LABA and ICS alone is not recommended. Whenever we are thinking to add ICS, there should be LAMA also. There's a triple combination we should use in such patient. And some patient, in spite of LABA, LAMA and ICS, still they get the exacerbation. To reduce the risk, there are other options with us, such as anti-inflammatory therapy with azithromycin or erythromycin, and also roflumilast is also one of the drug that shown to reduce the exacerbation on the long-term use.
Go ahead, please, Harshita.
Yeah. Yes, ma'am.
So I think this was some of the data that tells us about how inhaled corticosteroids in exacerbations, especially in patients who have COPD with eosinophilia, these are the trials which showed that they help in reducing the eosinophil levels and reducing the exacerbation. So I think your patient did have a high eosinophil count, right, Harshita?
Yes, more than 500.
More than 500.
He would be an ideal candidate for putting on an add-on inhaled corticosteroid. Yes, please go ahead. Let us know what you did.
So we initiated him on an inhaled corticosteroid, as you said, along with a LABA and LAMA. And these are the various interventions that reduce the frequency of COPD exacerbation. We have bronchodilators, corticosteroid-containing regimens, which is LABA plus ICS, LABA plus LAMA plus ICS, anti-inflammatory drugs, non-steroidal, which is roflumilast, anti-infectives, so we have to vaccinate the patients, and long-term macrolide can be given to the patients. Mucoregulators like N-acetylcysteine, carbocysteine, erdocysteine, and various other interventions should be done. Smoking cessation is of utmost importance. Rehabilitation of the patient. Lung volume reduction surgeries can be done. Vitamin D supplementation is important, and some shielding measures like mask wearing, minimizing social contact, frequent hand washing to avoid infections in such patients, which can be one of the most commonest causes of exacerbations in COPD. We did
follow up. That's a good point you brought up, Harshita, because I think all of us during COVID, we saw decreased number of exacerbations in all our airway disease patients. I think because of social distancing, they definitely had decreased number of exacerbations. So I think this is something new that has been added in the recent guidelines also following this evidence. Yes, please go ahead.
So we did follow up with our patient, and patient is doing good, symptomatically better. Dyspnea has improved. There is no exacerbation, but patient continued to smoke. So what other measures can we guide the patient for his disease, and how?
Yes, Dr. Savla. when this patient comes back to you, what would you do?
So one point which she mentioned very nicely on follow-up, that everything got better for the patient, but he didn't improve himself. He continued smoking. So this is where now he really needs help, really needs guidance. So maybe we can go for a professional help where, he can join the groups which will help him to quit tobacco. There are certain social groups he can even, we can increase his willingness, involve his family, so that we can help him in quitting smoking, because we need to make him understand that all this smoking, the tobacco, is the reason for him to worsen even in future, and that is why he needs to take that seriously.
Great. I think that is something we should all reiterate at every visit, because often patients sometimes stop smoking and then restart again and don't tell us that they have started, and we assume that they have stopped smoking because they've given us history of stopping smoking. So that is also another point often, that every time we must ask whether they are, they've managed to keep off smoking, have they stopped, or if they need any assistance with that. Yes, Chandrakant, you have anything to add, please, in this?
Definitely, ma'am. We should whenever every visit, we should ask them, and we should advise them to stop it. And definitely, we should give them plan, and we should help them. Nowadays, many effective therapies have come.
Yes.
Especially some patient with the nicotine chewing gum, they feel it's boring or something. It's every time they have to chew it. Some taste problem also remains with the nicotine chewing gum. But nowadays nicotine patches are available, which is easy to administer. 24-hour acting is if you apply the patch over the skin, it will act for 24 hours. And over a period of 2 to 3 months, many patients, they are able to quit the smoking without much any side effects.
Correct. I think we have to keep counseling them, and along with asking them and advising them, we have to refer them to other, social groups which have benefited with stopping smoking. Now with this era of social media, there are lots of groups available, where a lot of patients help each other in various diseases. And of course, as you said, when pharmacological therapy for smoking cessation is needed, we must send them to a center or a pulmonology clinic that is actually actively doing this. Yes, please go ahead, Ashita.
Yes, ma'am. Also, ma'am, if I may add a point,
Yes.
that in nicotine quitting, we should stop. It is recommended in the guidelines that we should stop criminalizing the fact if they
Yes.
start smoking again. We should not consider that as a failure, and we should not make the patient feel as if the patient has
Feel bad.
failed
Yes.
if he or she
Correct.
has started smoking again.
Correct. So a lot of times, especially in our country, I think smoking is considered a taboo. So we don't, patients are also not very forthright in the response, how we treat them when they've started smoking. Instead of being empathic, we, as you said, if we start accusing them of, not being good, then it becomes difficult. Sure, that's a good point, Harshita. Please go ahead.
Yes, ma'am. That's the end of my case. Thank you so much.
Great case, Harshita. Thank you. Chayan, can we move on to the next case, please?
Yes, ma'am.
So while he's getting ready with sharing his slides, so I think basically what we understood from this first case is that not to start inhaled corticosteroids and LABA as a main primary therapy, which what happens in our country is that because any airway disease gets started on ICS LABA directly, right? So I think that is the one thing that we have to understand. Preferably in a COPD patient, start a LAMA, add on a LABA. If not improving, then you go to the third step, which is adding on an inhaled corticosteroid or deciding whether the patient fits into any of the other categories for another anti-inflammatory drug. Yes, please, Sharon, go ahead.
Is my screen visible, ma'am?
Yes.
Good evening, everybody. My patient is a 52-year-old male patient presented to us with complaint of shortness of breath and of MMRC grade 1, which is progressive in nature and increased during exercise. He had complaint of wheezing, cough with occasional mucoid expectoration for last 3 months. There was no history of atopy, no history of allergen exposure. He is a reformed smoker of 35 pack year. No history of rhinitis, GERD, OSA, or no history of anxiety or depression was there. His father is a chronic smoker and he has history of allergy. By profession, patient is an IT professional. Among the past history, he had no history of tuberculosis or no history of childhood infection, but patient has history of taking azithromycin and nebulization in view of shortness of breath and cough 6 months back. And he had another episode 3 months back of cough and breathlessness requiring antibiotic and oral steroid also. There was no complaint of sneezing, running nose, watering eyes, or throat pain. Currently, patient is on ICS plus LABA on SOS basis, which is giving him partial relief. On examination, there was no respiratory distress. Patient is on room air therapy, and all systemic examination was within normal limit. This was the X-ray of that patient, which is showing no significant abnormality. Sputum examination, AB smear and CBNAT was normal, negative. And in lab parameters, patient has absolute eosinophil count of 46. CAT score was calculated, which was 16. This was the PFT done on presentation, which is showing in scooped out appearance in the curve with FEV1 FVC ratio of 68.65 with FEV1 of 59% and FVC of 94% with preserved TLC. This was the CT scan showing paraseptal emphysema. So on these, patient was diagnosed as a case of COPD group E, as the patient had CAT score of more than 10 and he had also history of 2 exacerbation in past 6 months. So now coming to the first question, this patient was on LABA and ICS on SOS basis. Is that the correct initial therapy for this patient?
Yes, please go ahead, Chandrakant, if you would like to elaborate.
As we are discussing last case, ma'am, only his first drug of choice should be LAMA. If still symptoms are there, we should have the LABA. And then next step is ICS. As in this case, the patient was using ICS plus LABA or SOS basis. That definitely is not a correct treatment. That's why such patient should be on the combination inhaler with the LABA and LAMA.
Okay, great. So I think there is some more data which is shown. It's just again a recapitulation of the data. Please go ahead.
So we started our patient on LABA, LAMA and ICS triple therapy.
Okay. Now, so I think last time also there was a discussion about this patient categorizing. Some of the panelists thought that this patient should go into category B, and half of us were divided about it, the patient going into category E because of the exacerbations. But I think here we have to remember that the patient is treatment naive because he's on SOS, ICS, LABA. So if somebody wanted to just start him initially on a LABA-LAMA combination, it may not be a completely wrong choice with a close follow-up. And then add on an ICS if the exacerbations continue. Yes, Chandrakant, is that what, because I mean, if the patient has not been on regular therapy, I mean, there could be a call, somebody might decide to initially start on triple therapy versus starting a LABA-LAMA combination. I think that's an individual thing, how closely you're able to follow up the patient and the patient is able to record his symptoms.
Yes, as per the guidelines, LABA-LAMA should be the ideal combination in the stage E of the COPD. But as this patient having 2 exacerbation, I think this is also a good choice to add the ICS to LABA and LAMA. And definitely there are definitely other reasons. If there is a concomitant asthma, we should use the ICS is mandatory. And additional factors, if the patient is having eosinophilia and previous history of exacerbation, in these are the strongly recommended criteria for adding the ICS to the LABA and LAMA. And other thing areas where we should not use, especially if the blood eosinophils are less and the patient is getting recurrent pneumonia, because ICS are implicated for the increased pneumonia incidences in patient with the COPD. And in such cases, we should avoid it. And the patient with the history of tuberculosis or active tuberculosis with COPD, we should avoid using the ICS.
Correct. Okay. So I think again in this context, this patient, I don't know, did he get oral steroids on both the exacerbations, Shayan? I mean, because he's fitting into 2 moderate versus 1 mild, 1 moderate exacerbation, right?
Last exacerbation, patient took oral steroid.
Okay.
3 months back.
So he's a little bit of a borderline case, and I think you've put this case so that we can discuss how different people would probably initiate treatment, and both may not be wrong in someone would directly, based on the criteria, put him on all three drugs. Somebody would put him on a proper LABA/LAMA follow-up therapy, compliance, adherence, and then decide over the next 1 month to decide how to go ahead. Yes, please go ahead.
Now, on follow-up, patient was symptomatically better for initial weeks. Within 3 months, he had another exacerbation, and other comorbidities was readdressed, and inhaler technique was checked. Now, coming to the next question, how would you review and reassess this patient?
Yes. Dr. Hani, would you like to please? Hani, you're on mute, please.
Yeah, now I'm audible.
Yes, yes.
Yeah, for this patient, we have seen that we have given appropriate treatment. In fact, we have even given ICS also was added, but something is going wrong with this patient, that he's again and again developing exacerbation. So this is a time when we should look for other causes of dyspnea also, that whether it is because of cardiac cause or there is any other particular reason which is causing, and not just this disease. If we have ruled out that, then we can consider escalating our treatment, adding azithromycin, preferentially if the patient was a smoker, and otherwise we would try to add roflumilast or something and continue the treatment, assess his response, look at his compliance, look at his adherence, and keep him on close follow-up. But main thing is that we should not miss out on other causes of dyspnea also, and pulmonary rehabilitation, a little bit underestimated but really important step, also should be considered properly in this patient, and he and his relatives should be educated about the importance of rehab.
Correct. So
And
I think
one thing
yes.
I wanted to add, ma'am,
Yes,
as we are seeing the patient still getting the exacerbation of the triple drug therapy, that is ICS, LABA, and LAMA. In such patient, as Dr. Hani said, we should rule out the cardiac causes. But in addition to that, we should rule out the additional comorbidities such as bronchiectasis or some malignancy. So that definitely in such cases, CT scan, I think, will be recommended. So that we can rule out any additional causes or additional pathologies, and even that will help for the treatment aspect also, including the surgeries.
Correct. So this patient, I think, already had a CT scan done. So
Yes.
there was no bronchiectasis,
Yes.
but he did have extensive emphysema. And there was some early bullae also forming. And I think in this patient, can we move ahead? What was this exacerbation because of? Chan, because now that on inhaled corticosteroids, if the patient is having a recurrent exacerbation, Chandrakant, what would you be worried about? Would you think that, would you de-escalate the ICS because you have started it for exacerbation, it's not working? So would you think that the ICS is causing a pneumonia? When would you de-escalate the ICS also?
In the cases of recurrent pneumonia, we can think on that, but I think definitely there was no, I think, incidence of pneumonia in this case. Only exacerbation was there. The details are not there, but I think I will continue the ICS, LABA, and LAMA. But additional pharmacological options, I will think, as discuss long-term azithromycin, roflumilast, and even other things to prevent infections. I will go ahead to the vaccination, especially flu vaccination, pneumonia vaccination. I will think on that.
Okay. Please go ahead, Chair.
Now, what are the other pharmacological options available for these kind of patients?
I think that has already been partly discussed. Please go ahead. Yeah. I think Dr. Hani has already mentioned specifically about this. But just to recapitulate, I think if the patient's lung functions are severely poor, if it's less than 50% in FEV1, then you can add PD4 inhibitor like roflumilast, which has been shown to have some effect. And if the patient is a smoker, which your patient was, you could think of giving long-term azithromycin, but under careful monitoring of ECG, because you don't want QTC prolongation, right? And you also need to look at hearing, if there is any hearing impairment on these drugs. I think as far as mucoregulators, there is equivocal evidence, so we don't usually routinely recommend it. It is more patient to patient and individual. And leukotriene modifiers have not been really tested in COPD patients. Unlike there is evidence in asthma, but in COPD there is no evidence. Yeah, so I think this is just some more data telling us about macrolides in smokers reducing acute exacerbations. Yeah, please go ahead. Yeah.
Now, coming to the next question, how to decide tapering or discontinuation of inhaled corticosteroid?
Correct. So I think Chandrakant, I mean, when you start add-on ICS to a LABA-LAMA combination, is there a dose that you decide? Do you continue that dose indefinitely? What do you do in clinical practice?
Usually, we start with the lowest dose of ICS.
Correct.
Normally, with the respect to budesonide, 200 to 800, 200 to 600, 800 microgram is considered a mild dose. 800 to 1600 moderate, and more than that is a higher dose of inhaled corticosteroid. And if you start on the low dose, if the patient is not having repeated infection and still having the symptoms, if there is no pneumonia, you can increase the ICS dose. But if the patient is getting infection, pneumonia, in that case, definitely we should step down the ICS. And in fact, sometimes if the recurrent pneumonia, we need to stop also. Just we have to consider the LABA and LABA only in such cases.
Correct. So I think the idea is to keep the patient on a minimum lowest maintenance dose of ICS, which prevents the exacerbations and also does not cause any side effects. I think, am I correct? Is that what you're trying to say, right? Isn't it? So
yes.
Initiate also, and if at initiation you need to step it up, then once the patient stabilizes, you do try to get it down to the minimum lowest dose possible. And if possible, to try and get the patient off the drugs also if needed. Yes, please go ahead.
Now, the next question is, what are the other non-pharmacological options?
Yes, Dr. Sabla, what else would you advise your patients?
Yeah, so the one thing which I already spoke about was pulmonary rehabilitation. We need to emphasize the importance of this rehab thing for all our patients. They should go for a pulmonary rehab, which can help to improve their strength as well as improve their lung function test, as well as help them to have less exacerbation. Since the patient is smoker, smoking cessation is there. And the one most important thing which all of us should remember on every follow-up is to check on their vaccination status. So COVID-19, though it was a pandemic and everyone wanted, and they could very well, finish the COVID-19 vaccination. But that's not the end. We should encourage flu vaccination and once a year pneumococcal vaccination, which is given to the patient. And also consider for the diabetics and COPD shingles vaccination also, or those who are requiring steroids for pretty long time. We have an addition of shingles vaccination also, which is available by one company. So they should also consider using that. This will help to reduce morbidity, mortality, and hospital admissions.
Correct. Okay. So I think, Chand, your next question. Yeah.
So vaccination.
Yes, I think she has already covered this partly. If you want to just move ahead, is there some new recommendations also by the gold guidelines, Dr. Chandrakant, other than what Dr. Ani has already said?
Yes, apart from the flu vaccine and pneumonia vaccine, there is additional, we can consider the shingles vaccine for the COPD patient, and also
the zoster vaccine is a new introduction,
yes.
Right?
Yes, ma'am.
I think we are going to soon get, I don't know if it's already launched, but it was supposed to be launched in India. Though it is a little expensive, but zoster vaccine has also come to India for adults.
And obviously COVID-19 also we should consider.
Yes, great. Okay. So I think that we are very clear on. Sometimes I see some of our own patients, who have been seen by one of us, sometimes we miss it out. So I think that is very important to always go back and look at the vaccination status, because we know that the evidence says that it may not prevent the episode completely, but it definitely decreases the severity of the episode, and which is what we want in our patients. We don't want them to get indoors or get to the ICU. Yes, please go ahead.
Next question is, should patient be referred for pulmonary rehabilitation?
I think Dr. Ani Sabla has already mentioned this, and yes, please. If you want to elaborate a little more on this, Chandrakant, why we are saying,
pulmonary rehabilitation, especially is recommended for Group B and Group E cases of COPD, and it's need not necessarily we have to start in the very later state, but when the patient started getting discharged also, that time also we can start with the basic exercises. And there are enough studies which showed that it reduces the recurrent hospitalization, it improves the quality of life, if you start the rehabilitation earlier, post discharge from the exacerbation, and it increases the exercise capacity and muscle mass also. That is the advantage of the pulmonary rehabilitation.
Correct. And I think one important thing here is, I don't know if we are going to talk about it, is but nutrition. I think that is one aspect that sometimes we forget to tell our patients is about their nutritional health. That we need to put them on a high protein, low carbohydrate diet, especially in the advanced COPD patients. And the other thing is that some of what I have seen is some of these advanced cases, they have this misconception that if they mobilize themselves too much, they will get more breathless, but not realizing that there'll be muscle deconditioning and that will further cause them, further breathlessness. And there are actually very nice, if you go through some programs, they will tell you how patient has to basically do his day-to-day activities, especially when the patient is in severe COPD. So patients are not concerned about what is his lung function, what is his exacerbation, whether he will die of the next exacerbation. He will come and tell you, okay, doctor, once I take a bath, I have to stop to wear my clothes. If I bend down, I cannot bend down, frequently in the day. I cannot sit in one position for a particular amount of time. So I think these are the certain things that we as physicians, as busy physicians, don't have time to counsel, and actually explain to them, where this integrated pulmonary rehabilitation program will really help. They will actually be able to spend time with the patient and guide them how to do small basic changes in their day-to-day activities so that they don't feel so breathless. Yeah.
One more addition to what
Yes.
you said, ma'am, because
Yes.
they are also pretty homebound, they have vitamin D deficiency, and they
Yes.
are also at the risk of osteoporosis also.
Yes. Yes.
Many of them don't do DEXA scans and don't take the treatment for it, and then they end up in the casualty with some fracture, especially the elderly with spine fractures.
Yes. Yes.
And then the whole thing gets complicated. So that also needs to be addressed time and then.
Correct. Yeah. Yeah. So well said. I think please go ahead, Yash.
Next question, would you consider this patient for long-term oxygen therapy or home NIV therapy?
Yes, Chandrakant, please.
Patient with the stable COPD or some moderate hypoxia on exertion, usually giving the oxygen may not help much in respect to the mortality. But definitely patient with the severe chronic resting hypoxia, that is a PaO2 of less than 55, or and if the patient is having simultaneously pulmonary hypertension, even if the PaO2 is less than 60, we should consider the long-term home oxygen therapy. In respect to saturation, the cutoff is less than 88, less than or equal to 88, without pulmonary hypertension. If there is a pulmonary hypertension, even if the saturation is less than 90, we should consider for the long-term home oxygen therapy, which can increase the survival in such patients. And related to the ventilatory support, BiPAP or NIV definitely help in the patients, especially for the acute exacerbation. But for stable COPD also, if the patient is getting recurrent admissions for the type 2 respiratory failure, so this BiPAP, this NIV will help them. If you give the home NIV, the recurrent admissions for the COPD exacerbation or type 2 respiratory can be avoided. That is the benefit of the NIV in such patients.
Correct. I think there is one large trial, which was a hot NMV trial, which really put the nail in the coffin about how earlier some of us were prescribing NIV to patients at home, but we didn't have that much substantiated guidelines which included this. But yes, it decreases the frequency of repeat admission, exacerbation, and even mortality. NIV in the correct group of patients. Now, as far as oxygen therapy, I would like to add something. I think all of us need to tell our patients how much oxygen to take. Yeah, because I think sometimes you have patients who will decide, okay, I've been prescribed oxygen, so they will take high oxygen and then they will come back with CO2 retention, especially our COPD patients. So I think that is also important, along with when we are prescribing home oxygen to COPD patients.
And even, ma'am, related to air travel,
yes,
if saturation levels are above 92, 94, then patient can travel safely. But below that, we should advise the in-flight oxygen therapy, especially the patient with the hypoxia. And even those patients already on home oxygen therapy, if they are requiring some 1 liter oxygen at ground, definitely we need to increase to 2 liter, 3 liter in the flight.
Correct. Correct. So I think air
The
travel
flight
is
will have normally at ground level, we inhale the 21% of the oxygen. With
yes.
the flight, they are pressurized and it will be only 15% oxygen we get in the flight.
Correct. Correct. So a lot of our COPD and other ILD patients do have desaturation on the flight, and often they don't. Often when you tell them that you please, get a form filled and ensure that you arrange for oxygen on flight, they don't listen to you, and then they come back after flying with an exacerbation because they have put their lungs on pressure. Yeah. Good point, Chandrakant. Very good point. Please go ahead.
In our case, patient had room air saturation of 94%, and in ABG, their PO2 of 59 and PCO2 was 47.
Okay. So
now coming to the next question, are COPD patient at increased risk of other comorbid conditions?
Yes, Dr. Savla, would you like to take this? You already mentioned osteoporosis.
Yeah. So yeah, agreed. So osteoporosis is there, and they can always develop cardiovascular diseases called pulmonary respiratory infections can occur. They can develop lung cancer. So because we have to, for this only, we have to screen them and follow very judiciously. Because of the use of steroids, they can develop diabetes sometimes and bronchiectasis. So these are certain complications which can develop in our patients and they need to be addressed. In this, I would add asthenia also, which you have very nicely said that why nutrition is so much important.
Correct.
So these are the certain things that they develop over a period of time, most of them.
Great. And I think sometimes when they are homebound, as you said, they also get very depressed, because they feel socially isolated, especially in our country where going out of the house, meeting up with friends, family, relatives is so important. They get very depressed. And so that is another aspect that one should look at it and see if they need any help in counseling to overcome their, issues related to their disease. Yes, please go ahead.
Agreed.
Going to refer the patient to specialist.
Yeah. So, honey, you've been managing this patient very well. When would you decide to send to a pulmonologist?
Yeah. So I think it is always good to take an opinion of a specialist, especially when we have some diagnostic dilemma, or else if there is an onset of call pulmonary, you want a cardiologist to be involved, or else you want to assess the oxygen therapy. If the patient is advised long-term oxygen therapy, what measures we can tell what level they can take. And if there is a rapid decline in FEV1 in spite of all the best treatment, then we should refer to a specialist. When the rehab is required, there are good physiotherapists who are now very well trained in pulmonary rehab specifically. If required, certain patients may also require lung volume reduction surgery and lung transplantation. So we need to refer to the required specialty for the same. Frequent infections, if they are occurring, we need to refer. And hemoptysis, if it occurs, we need to dig in more and see what is the basic reason behind it. If there is a severe exacerbation which cannot be managed, I feel we should always involve a specialist, a pulmonologist, who can guide further about the treatment. And any patient who is not improving or deteriorating despite therapy, I will always like one more special person to have a look and guide us on the treatment. It is always better when two minds think for the same person. So it's a multidisciplinary thing eventually.
Correct. I think often your COPD patients have a physician, have a their family physician, have a physician, have a cardiologist and a pulmonologist looking after them, because it is a multi-system disease at the end of it, because a lot of them have been smokers, so they have other systemic involvement. So definitely it becomes like a multi-speciality treatment plan. Yes, please go ahead.
Now, once referred to you as a specialist, what could you offer to the patient?
Yes, Chandrakant. Now the patient has come to you with high expectations.
Ma'am, there are various advances in the pulmonology, especially in respect to the COPD. We have various bronchoscopic lung volume reduction methods also. There are some subset of patients with the chronic bronchitis variety of COPD. There will be increased mucus production. In such cases, therapies available are the nitrogen cryospray and rhinoplasty, basically in which bronchoscopically there will be ablation of the mucus gland that secretes more mucus. These are the therapies that we can give. And patients with the recurrent exacerbations, those who are having bronchitis, bulle, emphysema, in these cases, we can consider targeted lung denervation. This is also a novel technique of the bronchoscopy in the management of COPD, where the denerving of the parasympathetic nerve will be done. And what are the clinical consequences of cholinergic hyperactivity are there? That is leading to the COPD symptoms that can be reduced with the targeted lung denervation with the bronchoscopic innovative technique. And a patient with the dyspnea because of the bulle, emphysema. In this case, especially if the bulla is larger, occupying more than 30% of the lung, in this case, we can do the bullectomy. And in some cases, for example, the COPD, there will be increased lung volume and diaphragm become flat. In that case, and patient will get dyspnea because of the diaphragm will not be effective generator for the respiration. In that case, if you reduce the lung volumes by the bronchoscopic wall or coils, the patient get the decrease in the symptoms, and recurrent exacerbation can be reduced. And even there are other methods also, lung sealants, means we can, if the patient is having some isolated lung this bulla or some we can introduce some lung sealer so that that volume will be reduced and bulla will get collapsed. So these are the different varieties. And definitely lung volume reduction surgery also shown to improve the survival in the patient and also the quality of life. And the last and not the least is the lung transplantation. Over the last decade, there's a significant increase in the number of cases of lung transplantation, especially in the COPD cases. And with this, there can be also, although it's the initial stage in the India, but other countries, they have achieved good outcomes and even the longer survival in the patient with the lung transplant.
Correct. I think in our country, because lung transplant is still done in limited centers, it's mainly ILD patients who are being transplanted and being referred for transplantation. But in the West and in the European countries, COPD forms a major chunk of their transplant program also. So I think going forward, as our transplant programs increase, we have more donors, we have more centers, maybe there will be patients of lung COPD patients also who fit the criteria will be being referred for transplantation. And of course, as of now, we don't have this endobronchial coils and valves in our country, but there is data on that for bronchoscopic reduction. And of course, you have other methods bronchoscopically, and then you have the surgical methods. So are we towards the end of your slides, Chayan, or do we have more discussion?
No, this is the end of the slide now.
I wanted to have actually a couple of questions and thoughts that came across in my mind while you all were presenting was that this patient of yours, I think he was a smoker and he also had work exposure, right? So yes, that is an interesting thing because you can counsel how do you, exposure at work is something quite tricky, no? Chandrakant, how would you counsel him? So that's a bit of a tricky part. Though now I think increasingly now you can't smoke in public places. You have to go to dedicated areas to smoke. So maybe you counsel the patient not to hang out on those areas, right?
Definitely, ma'am. Apart from the smoking, there are various risk factors, as you told, occupational exposure. Correct. Even the females in India, especially in the villages, biomass smoke exposure. Correct. These are the important risk factors for the COPD. And we should advise, especially for the females, we can advise to avoid the biomass fuel smoke exposure, the ladies from the village. And nowadays, definitely the LPG gas being used more frequent in the villages also. But occupational exposure is still more common because of industrialization. And people, they don't think much seriously in respect to this occupational exposure, because this is also as dangerous as smoke, also normal tobacco smoke. So they should stop it. If the exposure is not avoidable, if the person is not able to leave the job, at least we can advise them to use a proper mask at the workplace so that they can avoid the exposure.
Correct. And I think in our cities now, Delhi especially, and this year even in Mumbai, the air quality was very poor. So I think outdoor air pollution and acting as a trigger is for exacerbations in already patients with poorly controlled COPD, poorly controlled lung functions is another main factor. So there again, I think we should advise patients what to do. Limit your outdoor exposure, try and wear a proper mask, lots of other things, avoid traveling at the time where the precipitate temperature is low, where again it is towards late night, middle of the night, where again more dust settles into the inhaled level. So I think some of these, like especially now that air quality in certain urban cities is definitely a problem, and it's going to be an increasing problem if we are not able to control it. Yes. Another thought that came up in my head was about lung functions. We have talked about spirometry in the last webinar being a cornerstone and can be easily done up for the diagnosis. But is it useful in monitoring? I mean, do we need to do it frequently? Or, is there some guideline 6 monthly, annually, or is it going to really change our course of management? Not really, right? PFT, it's more for a monitoring purpose to see if there is any deterioration so that you can risk stratify the patient, because the PFT doesn't really decide our treatment protocols in COPD patient. It just helps us figure out whether the patient has got poor lung function and maybe at more risk of developing an exacerbation, right? Chandrakant, what would you do?
Yes, ma'am. For diagnosis, definitely the PFT is mandatory. But in the follow-up, basically more it depends upon the number of exacerbation and the symptoms, hospitalization. So stepwise, we need to address the issues. We can add on the drug depending upon the symptoms, basically CAT score or MMRC dyspnea score, rather than just on the PFT.
Correct. Okay. So we haven't had much any other winding up questions that Harshita or Chayan that have come to your mind during the presentation that you would like to discuss with the panelists, or any other points, Dr. Chandrakant, Dr. Savla, that you would like to discuss which have not been specifically asked in the presentations? Please feel free.
I think, ma'am, we have covered most of the points.
Correct. I think we've not gone into too much detail about specifics about oxygen therapy, home oxygen, NIV and all, because this is more for, peripheral and physicians. And I think that part is mostly then landed up being managed by the pulmonologist. But I think we've tried to cover basic stable COPD, how to manage, how to escalate, how to de-escalate treatment. And I think at the end of this, what we would like to wind up saying that please do not start your patient on inhaled corticosteroid if you're diagnosing COPD at the outset. Your main therapy still remains LAMA plus LABA, then inhaled corticosteroid comes later. Do not add it unless there is already a LAMA-LABA going on and the patient is not yet controlled, is still having recurrent exacerbations. So inhaled corticosteroids add if the patient is having recurrent exacerbations. If the patient is not having exacerbations and is more having dyspnea, then see what is the problem. See whether the inhaler technique is not correct, whether he is not taking it as per the prescribed dose, whether the type of therapy that you have prescribed to the patient is not appropriate for him. Like if you prescribe a DPI, then you should move to an MDI or vice versa. Add on a spacer in if you're giving an MDI, because a lot of these patients have poor hand-to-mouth control. So remember, if you're using a meter dose inhaler, please always use spacer. If you think a patient is not going to take either of them and it's because of the technique, then feel free to even move on to nebulized therapy at home, which can now be easily managed. So I think with that, I will wind up this session. And I think the next session that we are going to have is on obstructive sleep apnea, which is going to be on the 10th of June at 8 p.m. So looking forward to meeting all of you again. Thank you, Harshita and Chayan, for the lovely cases and the presentation.
Thank you.
I have to extend a warm thanks from both Indian Chess Society and from Agam on behalf of API to Dr. Chandrakant and to Dr. Hani Savla for their excellent discussion, their excellent inputs, and this absolutely wonderful session on management of COPD. Thank you. Good night. Bye, everyone.
I take this opportunity to thank all who have joined this webinar, which is EPICS for physicians and
Great,
respiratory
Chandrakant.
physicians
Thank you.
combined under the aegis of Indian Chess
Good.
Society and Association Physicians of India. I hope you liked it. Do get the feedback to us and we will try to definitely incorporate them in the future series. So keep tuned and watch each and every episode and give your feedback to us. Thank you very much.